chance to teach hematology for 20 years in the medical college till I took my voluntary retirement from the service in year 2001. So Dr. Ramdev does not need any introduction, and we are very happy, and we this lecture of Dr. Borges in memory of Dr. Ramdev. It is great pleasure and a great tribute to the finest gentleman, and then about his humanitarian attitude. He was a great human being. He actually never behaved as a HOD, and when we worked under him, we never felt that he is our boss. He used to treat all of us as his friends, and he was a great democrat. In the academic discussions, if something happens, we used to discuss everything with him. If in any moment we discussed and he corrected us, then later on, if we were right, in the morning, next morning in the tea club before everybody, he will say that, no, Dr. Mehta, you were correct, I correct myself. So what I mean to say that he was a great democrat and a great human being, great pathologist till he lived, and he expired in the year 2022. I pay my heartfelt gratitude and homage to Dr. Ramdev, and I hope that this lecture in his memory will continue for time to come, in the years to come. Thank you very much.
Thank you very much, sir. I would like to invite Dr. Anita Borges, ma'am. Well, ma'am needs no introduction, but still. Ma'am is the lab director of the Center of Oncopathology, Mumbai, head of histopathology, SL Rahajab Hospital, Mumbai, chairperson of the Advisory Committee for Medical Labs, NABL, member of the Education Committee of the International Academy of Pathology, and passionate teacher who believes in opening minds to possibilities beyond the mundane. Thank you.
Thank you so much for that kind introduction. And thank you, Professor Purohit, for having invited me to this lovely city of Jodhpur. I haven't been here for many, many, many years. I think perhaps the last time I came here was when you had arranged a conference many years ago. One minute, can we leave Professor Ramdev's... I feel really very honored that I have been asked to pay this tribute to the memory of Professor Ramdev. Of course, he was much before my time, and I did not know him at all, but having heard Dr. Mehta speak about Dr. Ramdev, I feel that he is a teacher after my own heart, because it is really, to me, teaching is the epitome of what we do as in our professional lives. It really brings joy both to the person who is teaching, and I hope it brings a lot of joy to those who learn. And today I am, during my little talk, going to refer to what learning is and what teaching is, because I believe that curiosity is the basis of good learning and good teaching. And I'm so happy that I'm standing here today to pay tribute to the memory of Professor Ramdev. So with that little introduction, of course, you see this iconic fort here at Mehrangarh, which I just saw from afar yesterday. Thanks again to the hospitality that I have received at Jodhpur. Thank you, Chetna, as well, for taking us around. I chose this subject of, let me see if I can Put it, yes, it moves. Curiosity and context in medicine, because I believe that young people have to learn not just how to make diagnoses, but to look beyond what is the obvious. And you can't do that without curiosity, and you have to put everything that you see into a context. Otherwise, we run the risk of falling into various traps. So let me start with what is curiosity. Now, all of us know what curiosity is, but sometimes it bears a little bit of definition. And I believe that curiosity is this. It's a very strong desire to know or to learn something. I'm sure we've almost always, anyone, all of us, have felt this, curiosity to be something or the other triggers this curiosity, and we want to know what it is all about. And sometimes I think that if we could inspire in those who are learning this kind of curiosity, to pursue something, it would be, well worth doing. And I say that the strong desire translates as passion. And I try my best every day that I am interacting with students to instill in them that passion. Now, I'll just say one thing. I don't see too many postgraduates over here, but the few of them that are there, can I ask you how many of you actually went into pathology because you had a passion for it? I see just one hand going up over there, and I'm glad that most of you didn't put up your hands, because you're being true to it. Most young people today in pathology go to pathology because they didn't get something else. Today, the computer chooses for you what you will do. And then that brings a kind of feeling of, all right, I didn't get what I wanted to do, so I'll just go along with it. It is a kind of a go with the flow, not very interested. But I tell you, if you can, despite the fact that you didn't go into pathology because you really wanted to, if you can overcome that disappointment and actually say that I want to be, never mind that I didn't get pediatrics or medicine or surgery or whatever else I wanted to do, if I can just say every day to myself, I want to be the best damned pathologist that I could ever be, and develop a passion for something that was not your first choice, I think you will make very, very good professional pathologists. So the postgraduates over here, please try to overcome your disappointment and develop this passion, right? Because there is one thing I will tell you, that without passion, learning is extremely difficult. I always had a passion for pathology. It was something that I made up my mind a long time ago to do. I came almost by default to pathology. I wanted to be an obstetrician and gynecologist. I could have been it if I wanted to. I had the marks and whatever else. But believe you me, I'm a lazy individual. You might think I'm not, but I am. And to get up in the middle of the night and go and deliver babies and, all that sort of thing was too much for me. I needed my sleep. So I decided that pathology is a wonderful thing, to do. You didn't have to work that hard. But to me now, if you ask me, would I have done anything else? And the answer is no. It is such an inspiring profession. I'm not going to talk about the inspiration of pathology, but this is what I want to say to the young people over here. Without passion, learning is extremely difficult. And I, tell you that we use our curiosity much of the time in this kind of way. It's called perceptual curiosity. I'm not sort of going into there are about 30 different kinds of curiosity if you go and look up Google or one of these, sort of subjects where people talk about social interactions, etc. But This perceptual curiosity is sparked by specific events. And what do I mean by that? You see two people walking hand in hand, a man and a woman, and then your curiosity is sparked, right? You want to know who's that, why are they holding hands, what is their relationship? They may be brother and sister, but you know what your mind will keep on thinking? Well, that kind of curiosity is there in all of us. Yeah, we like to sort of follow certain things, and I wish we could bring that curiosity to our profession. But I also want to tell you something, that deep down in all of us is what is called epistemic curiosity. It's a desire for knowledge in general. And that's because we are Homo sapiens. That is our genus and our type. That is Homo sapiens. And Homo sapiens is an intensely curious animal. And that is why we have explored the world. We are doing science, which is exploring what is the nature of the world. There is no other animal that does it. And Homo sapiens is an really intensely curious animal. And I love this quote of Albert Einstein. It says, "I have no special talents. I'm only passionately curious." And you have to take Albert Einstein at his work, because Albert Einstein was one of the greatest physicists of all time, who discovered many things just by asking the question, why? Okay? Now I'll just tell you what this curiosity is all about by illustrating two cases, and both of them are autopsy cases. And these were two cases that I used to supervise autopsies at Tata Memorial Hospital, oh God, many, many years ago. I doubt that Sumit or anybody else supervises autopsies now. We used to do autopsies at Tata Memorial Hospital, not a hell of a lot, but we used to. And I'll just tell you about these two cases because it just illustrates what I mean by curiosity. Now here was this 46-year-old male, very cachectic. He had obstructive jaundice, and it was known that he had a malignant tumor of the pancreas. His bilirubin, you can see, is very high at 16 milligrams. And he had a CT scan, right? 20 minutes after he was off the table from the CT scan, he died. And the cause of death was given. We had to do an autopsy because he had died literally after he had a procedure, and he hadn't been in the hospital for very long. So it was given as carcinoma of the pancreas with obstructive jaundice, okay? Because that's what there was on the autopsy table. There was no other reason that he had died. But I was not satisfied with that explanation for his death. And it was nagging me. Why did the patient die after a CT scan when he arrived completely unaided to the radiology center? The radiology center was in our hospital as well. I was not satisfied with that explanation that he had a cancer of the pancreas and he was, high bilirubin and everything, and his liver must have failed. To me, that didn't sound at all right, and I was curious. So what? Was it an acute cardiac death that took him away? Or as some people say, no, his time has come. It was time for him to go, and the time was picked like 20 minutes after the CT scan. I really wanted to know what actually happened to him. Okay, so I started questioning. And I went through his notes, and I talked to everybody who was there at the CT scan. And I discovered that the case was used for calibrating a newly installed CT scanner. So we had our first newly installed CT scanner at Tata Hospital at that time. The room temperature in the gantry room was 14 degrees centigrade. I feel terribly cold at even something as low as 20 or 19 degrees because I come from Bombay. A single, thin blanket was provided to this patient. The procedure took 4 hours. You know how long a CT scan takes now? It doesn't take more than 20 minutes, because we have faster scanners and all that. In that time also, it should not have taken more than about 40 minutes or so with the old scanner, but it took 4 hours. Why? Because they were calibrating that CT scanner. And the patient, I found, was moribund when the procedure was over. He couldn't even get off the table by himself. In fact, he had to be helped up, put into a wheelchair, and while he was being wheeled out of this thing to his doctor's consulting room, he died. So now, can anybody tell me why he died? Well, I think the diagnosis is very obvious. Yeah, anybody, any of the young people over there can tell me why he died? Yes, he died of hypothermia. Okay, now this is not something that you will be able to see in an autopsy. If you're curious enough, you will be able to find. And as a result of this investigation that I initiated, not to do an investigation, just to satisfy my curiosity, thereafter the temperature was made a little higher in the gantry room. People were given thick blankets to cover themselves. Okay, so the patient actually had hypothermia, and he was not in a position to withstand that, the extreme cold in that room, because he was already, compromised by, his jaundice and his cachectic condition. He had absolutely no fat in his body to withstand this cold. All right, I'll give you another example. Here is a male, again middle-aged at 47. He had a direct laryngoscopy that was done under short general anesthesia. The procedure went well. It took 15 minutes. He was fully awake. He was put onto onto one of these stretchers, and he just died while he was being transferred to the ward. He died in the elevator, in the lift. Now, obviously an autopsy had to be ordered, and there was absolutely no morphological cause that was found to explain his death. So now what do you do? I mean, in routine practice you send organs for or viscera for chemical analysis and all sorts of, but it didn't really need that as far as this patient was concerned. Okay, so you have to ask yourself, what are the causes of sudden death with no morphological findings? And I've just put up a whole list of them over here. Now, how are you going to figure that out? The only way to figure that out is to go and read the patient's case notes. Okay, so I got the patient's case notes, and guess what I found? After careful reading of all the clinical notes, I discovered that this patient was an old case of cancer of the larynx. That means he had a laryngeal cancer in the past. He had 2 previous major procedures under anesthesia, 2 years before this present procedure. On each occasion, the patient had suffered attacks of ventricular tachycardia, which were detected because the patient was being monitored under anesthesia. And the present anesthetist was unaware of this history of, because it was a minor procedure, and how are you, everything, take your blood pressure, this, that, and the other. And there were 2 separate files. There was one big file of the patient, which had all of this previous history, and one small file for the present admission. And the anesthetist had no idea that what had gone on before. And when you have a very minor procedure, it's usually assigned to a relatively inexperienced individual. Now, we all know now what must have happened to this unfortunate individual, young man, in the elevator. He probably had uncontrolled ventricular arrhythmia, which was related to his anesthesia. Now, if this history had been known, then of course the patient would have been monitored and not sent up, before the long monitoring that was taken. He would have been longer in the recovery room. So what I want to show by these 2 examples is not how smart I was. It is just how far curiosity can take you to try and solve a puzzle which is presented to you. Okay, and I urge young people to keep on continuously asking why. We ask a lot of what and how. What should I do? How should I do? And we are taught, what to do and how to do. But I submit that we are very rarely stimulated to ask why. Why should I do what I am told to do in the manner that I have been asked to do it? And I remember the days when, I don't know if you still do it, because there are some very odd practices that still go on. When we used to do blood sugar, in the urine sugar, not blood sugar, but urine sugar, in which we used to take 5 cc's of Benedict's reagent. Some of the, I see that there's a smile and a nodding of the heads of people in the front rows, etc. And 8 drops of, yes, you remember? Yeah. And everybody was told to do it, and we all did it, okay? And I remember when I was a second MBBS examiner, I asked one student after another, okay, why 8 drops? And what would happen if you put 6 or you put 10? Or instead of 5 cc's, you put 6 and not 5 and not 4. And there never was a student who gave me an answer, okay? And there are reasons for why we do this. It's not just do it because I'm telling you to do it. Obviously, this is not just it is a qualitative test, but it is a semi-quantitative test. And if you want to use that quantitation, however semi it is, you would have to standardize what was the amount and what were the drops. Of course, you know that people never took any pipette and put your 8 drops into it, but still, it was a semi-quantitative. And the question is, the real question, if you wanted to understand what it is that you were doing, and if the test had to be useful for whatever it was going, the use for which it was meant, then you had to understand why you were doing it in the way that you had to do it. And so you have to ask many of these questions. Why did this patient die? Or sometimes you actually have to ask the opposite. Okay, I expected this patient to die, but he's living. So why is this patient living so, so long? And of course, there is always the Uparwala to be thanked, but there is something very scientific at the basis of all of this. So I submit that the why question is what drives diagnosis and learning in medicine. Without why, I think we are robots, okay? And so this brings me to training. I told you I will tell you a little bit about training. And there are 2 words over here, training and education, and we often use them synonymously. And I don't like this word training. It's a word that has been entrenched in the English language by the Americans. Americans train everybody, okay? And what does training tell you? Training tells you what to do and how to do. Education tells you what to do, how to do, and why you are doing what you are doing. And I submit that we have too little of this why in our education system. We call it education, but we have very little of this in our education system in this country. We have a lot of memory and a lot of recall, but we really don't have true education. We really need more education than training. Now here's another couple of words, learning and teaching, okay? And I think we know in general what learning is. It is to gain or acquire knowledge, by study, experience, etc. But learning is not just about information gathering. I think that's something that we have to understand. It's not just about information, and in this day and age, there's a lot of information about. But just memorizing information is not learning. On the other hand, teaching is imparting knowledge. Yes, we know that. But once again, should not be about just giving information. And today, I know that in many places, and there is a lot of cut paste going on. Yeah, in your audiovisuals and other things, you just cut and paste, and that information is passed on. And I think the students are getting a lot of this kind of information, and they are expected to memorize it and recall it on cue. Okay? I submit that teaching is not at all about information. It is about helping someone how to learn. You know, I see an ad sometimes on television. It's some Kuwaiti foundation or something like that, and it says something about if you give a person food or fish, he will not go hungry in the short term. Okay? But if you want him not to go hungry in the long term, then you teach him how to fish. Yes, so to me, helping somebody to learn, to know how to learn, is really what teaching is. Anybody can get information, and today you just have to open your Google, and a lot of students think they are very learned because they can find the answers on Google, but I don't think that is really so. So let's talk a little bit about this. Information, knowledge, and wisdom. Okay? Information is about facts, I told you, and it is really the plague of our times. There's too much information. But I want to stress knowledge. Knowledge is the integration of these facts to create a base of understanding. If you don't understand the information that is thrown at you or that you have read or somehow or the other acquired, then you have no knowledge at all. You are certainly not learned. Okay? So I feel that we should not attempt, whether we are teachers or we are learners, to just acquire information without actually understanding what it is that we have learned. Now, wisdom is the third part of this, and I feel that wisdom doesn't come to all of us. The longer we have lived, and if we have really been practicing what, this whole question of knowledge, acquiring knowledge, then when we apply that in a very appropriate manner to an appropriate situation, then we can be said to be wise. And I love this quotation of T.S. Eliot, and he asks, where is the knowledge that is lost in information and the wisdom that is lost in knowledge? So too much information, too little knowledge, and even less wisdom is perhaps what I would say is the real plague of our times. And I'm just quoting this again. I mean, he's Dr. Ashok Chaudhary. I think Sumit might remember him. He was a radiation oncologist at Tata Hospital. He's very much alive. But he used to really bemoan the fact that all our residents would come to us seeking information. They thought that they were looking for knowledge, but they wanted to be taught. You know, he didn't teach me anything. The teaching comes from observation of what your guide or your mentor is doing, asking yourself, why is he doing this? Why has he asked me to go and find out this bit of information about a patient, and then learning from that how to go about whatever it is that you were doing. And I really appreciated what Ashok said, because I believe after all these so many years in this teaching and so forth, that learning is not a passive exercise. You can't sit somewhere, listen to a lecture and learn. No, it is an active exercise. You have to want to learn, and you have to be able to listen, to read, and then try and understand. And you can see that over here. No, there is a famous saying, you can take a horse to water, but you cannot make him drink. So learning is a very active exercise, and emphasis should be on curiosity. If you're not curious, if you don't ask why, then you're not going to really learn. Okay, I believe that the learning experience for students and teachers is to stimulate intelligence. And what is intelligence? I often tell my students, ask my students rather, why is the Central Intelligence Agency called the Central Intelligence Agency? What does this word intelligence actually mean? And when you think about it, what is it that the Central Intelligence Agency does? It collects information, then it analyzes it, and then it builds scenarios. Does that sound familiar? Of course it does. That's what we do every day in our diagnostic practice, whether I'm a clinician or I'm a pathologist or anything. What do? I make observations, I make interpretations of those observations, I analyze the whole thing, and then I build a differential diagnosis. So I'm doing that. So the part of the intelligence is an analytical capacity. So it's really an analytical faculty. And if we are not stimulated to analyze something, then I think that we have intelligence, but it is not being used, okay? So I feel that both students and teachers should welcome a discovery model, yeah, where students learn concepts from being encouraged to question rather than being directly instructed. And just think back at the way that we were taught or you are being taught and see whether this is what it happens in your everyday life. And so I would say the accent is on think. So you must think. Okay? So how should PGs learn? They must ask, they must be encouraged to ask why, and why again. Okay? I'm not going to ask you the question and answer it, but think. Why does one examiner slide at low power? Why shouldn't we just go to high power? Because we know that most people feel that, we are actually doing microscopy because we want to see everything at a very enlarged scale. So why should we go there at low power? Think about it, okay? Why is this, and I ask this to my students, a non-keratinizing squamous carcinoma rather than a solid adenocarcinoma? Interesting question. And there are very few people, because there's no keratinization. Otherwise, you ask a student, why is this a squamous carcinoma? Oh, it's got flat cells and it's keratinized, etc. But that's not the difference that makes the difference between a non-keratinizing squamous carcinoma and an adenocarcinoma. So you have to think rather than just say something that comes to your mind without thinking. Now, there are three other things that I feel that we don't think about enough, all right? Everybody, if you ask about dysplasia, you know what mild dysplasia is, and I'm sure that the students over here who have studied dysplasia, they will tell you that dysplasia is an abnormality that involves the lower third of the epithelium of the cervix. Yes or no? Oh, yes. Then why are we able to see this, make a diagnosis of low-grade dysplasia on cytology? There are cytologists here, right, in the audience. We are not going anywhere deep into that epithelium. We are just taking a brushing, or we are taking a swab or a scrape from the upper part of the epidermis. So what is the story of the lower one-third? And now I can make this diagnosis on the, or are we conning everybody and conning ourselves? No. We do make a diagnosis, and rightly make a diagnosis of low and moderate dysplasia. High grade everybody knows, because you've got, as we say, full thickness involvement. I'm not giving answers, I'm just telling you these are the questions that should excite you, all right? The next question, why do blastomas, except for retinoblastoma, why do other blastomas not occur in a familial setting? Because in a familial setting, and you know the whole story, you inherit, or the child inherits the abnormality in the retinoblastoma gene from either parent. Okay, so one of the chromosomes has it, and then Knudsen tells us that there is a second hit, and then you have the full-blown retinoblastoma. But every cell in our body has this abnormality. It's carried in every cell. It's not only in the retinal cells. So why don't we get other blastomas or other tumors in these patients? Ever thought about it? It's time to think. Okay? These are the puzzles, I'm telling you. Curiosity, oh, there are answers to all of this. I'm not here to give you answers, I'm here to make you think. And the third question, which is, this is chronic ulcerative colitis. There is Crohn's disease. There are other chronic inflammatory bowel diseases. Crohn's disease, other inflammatory bowel diseases produce fibrosis. Why doesn't ulcerative colitis produce fibrosis? It's chronic, right? And everybody says, chronicity means fibrosis. Yes, it does, with Crohn's, with other things, with tuberculosis. So why isn't it there in this chronic ulcerative colitis? Think. And then the answers will come, but you need to actually ask why. Yes, that is it. All right? And if those of you who would like to read a little bit of literature, there is this wonderful book by Lisa Sanders, it says every patient tells a story. Okay? Because she has put into that, encapsulated what it is that learning and teaching is. Okay? Particularly about teaching. You have to get students to think, and think. And teaching is offering to a learner the knowledge that has been gathered from experience and the way to gain insight. That's what we have to give them. Please, information is available everywhere. And teachers do this best by exposing students to a wide range of experiences. And not necessarily all of them are professional. Because to stimulate curiosity, you don't need to have slides or, grow specimens or whatever. Their life is full of experiences in which you can actually stimulate curiosity. And then when it comes to examinations, you should be testing their understanding rather than their memory. Okay? Now this was the famous René Descartes. He said, cogito ergo sum, which means I think, therefore I am. Somebody else said, not him, dubito ergo cogito ergo sum, which is I doubt, therefore I think, therefore I am. So this is what I would say in the first part of my lecture as far as curiosity. Curiosity is about asking why, and that translates to thinking. You cannot think unless you ask why. Now I'll come to context, okay? And context is a really very important part of what we do in everyday life. Whether it is making a diagnosis or also, like I said, you see two people holding hands, how you decide what that, the diagnosis of that is also dependent upon a context. And what is a context? Context is the framework in which you make your observations and ask your questions. All right, now there are two parts to context. One is reason and the other is judgment. Now, that reason, we believe that we are Homo sapiens, so the thinking ape, that's what Homo sapiens is. And reason is supposed to be the highest point of the achievement of Homo sapiens. And it is the ability to use evidence, and everybody talks now of evidence-based medicine, as the cornerstone of science or law. Everybody is supposed to gather the evidence and then make some kind of sense of that evidence. Okay? And reason, in its logical sense, is supposed to operate independently of experience. It doesn't matter, 2 + 2 will make 4, independent of where you are in this world, what your level of understanding or anything else. 2 + 2 makes 4, okay? And therefore, these rules are to be followed till their logical end. But on the other hand, you have judgment. Now, what is judgment? Judgment is about an opinion. And what do you think we give in histopathology every day? We make a decision, we write it down, and that is your opinion. We say that, no? That's your opinion, not mine. Okay. And we do this after consideration or deliberation. But the thing about this is that it is within a context. Okay? You cannot make a judgment outside of a particular context, and in these situations, rules may be disregarded in a particular context. Now I'll just give you an example. Here's the rule. Thou shalt not kill. If you do, you will be punished. Yes? That's there in our legal code. But now what about the context? Capital punishment by the state. That means the state kills people or it doesn't kill people? Yes, it does. No? What is capital punishment? Capital punishment is by hanging, it is whatever, electrocution in the United States or whatever. But if you do not get punished if the state is practicing capital punishment, or you are allowed to kill during war and you are allowed to kill in self-defense. So there is a rule, but it is not taken to its illogical conclusion because there is a context in which that rule has to be applied. Now here is another rule. Thou shalt not steal. If you do, you will be punished. And here is the context. All of you look at it. You have a hungry child caught stealing food. You're going to punish the hungry child? What? Punish or not to punish? And if you want to punish, what is the quantum of punishment? So you see the issue that you have evidence the child was caught stealing. You have evidence that somebody has been killed, but do you punish outside of a particular context? And the answer is no. Okay? Let's take another thing. Here is medicine. There is an evidence-based medicine guideline. The treatment of mild hypertension is a diuretic. Now I'll give you the context. Here it is. Middle-aged, heavy, osteoarthritic, recently widowed, never before hypertensive woman living in a chal. Now a chal in Bombay is, a series of rooms, and each of the rooms do not have their own private toilet. So you have to go to a toilet that is placed somewhere else. Now she's living in a chal where the toilet is Indian style and not on the same floor. And what does the EBM guideline say? Treatment of mild hypertension is a diuretic. So what is the judgment now? Your decision. Diuretic? No, you're saying no. But there it is, the rule, evidence-based medicine. Okay? It is probably not. A more appropriate treatment would be an anxiolytic and reassurance. So what does it tell you? That there are rules that in medicine in particular that apply to the general, but they have to be modified or can be modified given a context when it is applied to a particular. Now you might think, oh, that's all right, it's in, it's in life, it is in medicine. But I'm going to tell you that it happens every day in pathology, every day that we do work. And here is a 29-year-old male, son of a leading physician. Okay, and you know what is the biggest risk factor in medicine? Anybody can tell me what is the biggest risk factor in medicine? It is being related to a physician. Okay? Yes, it is. So anyway, this person, this young man had multiple cervical lymphadenopathy. He had a biopsy of a lymph node in the parotid region, and the block was sent for review with the diagnosis of mixed cellularity, Hodgkin lymphoma. Here it is. Okay, I'm not going to describe all this, but you can see that CD30, and it is full of CD30 positive cells. So some other pathologists looked at it, and saw all these big cells and a very moth-eaten appearance, etc., and said that this is Hodgkin lymphoma. Okay? Know what the context was? Because that's what I always ask. I always ask for a good history, clinical history. And the context was sudden onset of multiple lymphadenopathy. Now in the context of sudden onset of multiple lymphadenopathy, no matter how many CD30 positive cells, they may be even 15 positive and PAX5 positive, I'm not going to make a diagnosis of classical Hodgkin lymphoma. Why? because this is infectious mononucleosis. And I'm telling you, risk factor, I told you, you don't get sudden onset lymphadenopathy and Hodgkin's lymphoma even if you're related to a physician. Okay? So this guy had infectious mononucleosis. Good. Now here is an adult female skin lesion on the leg. Anybody want to tell me? It's obviously a squamous lesion, and you can see that it looks infiltrative. So what's the diagnosis? Squamous carcinoma. Yeah, you'd be forgiven for making that diagnosis. And now I will tell you the context and why we don't look only at high power. Okay, at high power this is squamous carcinoma, at low power it is not. Okay, so there is a reason for looking at low power because it gives you perspective. So here's this is the nodule on the leg. Started off as a pimple and it reached the size of 1.5 centimeters in 1 month. So what's the diagnosis? It's a keratoacanthoma. Okay, at high power that's a squamous carcinoma. At low power it's a crateriform lesion, and then you have the history, something that grew suddenly in 1 month, that is a keratoacanthoma. And this is the best of my examples. This is the excision of a mass on the palmar surface of the right hand of a 22-year-old recently married female with a 6-month-old child. Okay, the second opinion was requested before amputation of the wrist. There had been two previous pathologists who had called this syringocystadenocarcinoma. All right, and that's. Anybody have any dispute with the fact that this is, forget about syringocystadeno, but do you think that this is a carcinoma? And the answer would be, yes, of course it's a carcinoma. It is there in the slide. Do you know what my diagnosis was? Lipoma. Now you might think I'm screwy, right? How can duct carcinoma of the breast. So I, sort of spoke to the patient and I said, tell me something, how long have you had this on the palm of your hand? And she said, for 12 years. I said, oh, so why did you go and have it removed now? She said, I got married. My husband doesn't like the feeling of that thing on the palm of my hand. I felt sorry to have it taken out because it was like my companion. I used to feel it over there. So I said, can I see the surgeon's notes? And the surgeon on first examination said his diagnosis was palmar lipoma. See? So I said, where did, give me the original pathology report. The original pathology report said yellow, fatty, oily lesion. But the final diagnosis is syringocystadenocarcinoma. So I called up the pathologist who was from Bhopal, because this lady came all the way from Bhopal. She came with her father carrying this little child because the husband said that if your arm is going to be amputated, because it was right in the center of her palm, I do not want to have anything to do with you again. So it's the father who brought that girl all the way from Bhopal. And the pathologist tells me that he doesn't process stuff in-house, he sends it somewhere else for processing, that he sent the slide to a reputed lab which looked at the histology and said syringocystadenocarcinoma. So he wrote down syringocystadenocarcinoma, and then the lady was told that you have to amputate your hand. So she came to Bombay because she heard that there was, some practicing people in Bombay who do minimal surgery, to save limbs and all this, limb salvage surgery. And that person sent the case to me. And I saw this, and I'll tell you what was on that slide. You see this? There were two pieces of tissue. Carcinoma, and the other one was a nice lipoma. So I told the father that I don't think that this really belongs, this piece of tissue doesn't belong to your daughter. So he said, no, but her life is more important and this and that. I said, fine. So at my expense, I sent it in those days to CCMB. You know what is CCMB? It was a molecular lab in Hyderabad, which was a government lab. Of course, it was Center for Cellular and Molecular Biology. And I asked them to fingerprint this for the lady. And you know that the lipoma belonged to the lady, at least that lipid, and this thing is God knows who. So, what I'm telling you is that context is very important. Don't see something. Evidence tells you that this is a carcinoma. So there it is, lying on the slide. But evidence in medicine, 2 + 2 may not make 4. It may be less, it may be more. You just have to use the context, okay? So context, 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 my friends. History, radiology, and clinical findings provide context. Every observation must have an explanation. Please, nothing can be brushed aside. Why, I tell you, is a very important 3-letter word in clinical medicine, okay? It leads to context, which leads to a meaningful decision, which is otherwise called a judgment. And I give a little talk called Reason and Judgment, and I do it, and I give credit to this gentleman, Albie Sachs. You may not know, but Albie Sachs, you can see his right arm is just a sleeve. He has no arm over there. Okay, Albie Sachs was a member of the ANC, that's the African National Party of Nelson Mandela, when they were fighting apartheid in South America. He was sent into exile, and people were sent to kill him in exile. And the bomb was thrown at him in a neighboring country, and he lost his arm after really, almost spending 8 months in a hospital. He recovered. He went on to become the first Chief Justice of the Supreme Court of what is now the Republic of South Africa. He, like our Dr. Ambedkar, was responsible for writing the Constitution of South Africa. And he has written this excellent book. And if anybody really wants to read about, what is law and reason and one of the chapters there is reason and judgment. And what he says is, delivering a judgment is not dependent on personal taste, nor is it the product of a purely logical exercise. That means this is on the statute books and this is how I will rule, okay? Like the solution to a mathematical problem. It is the outcome of evaluation, of a weighing up of determinate factors, but in the light of agreed criteria. You must have some criteria, but in the context of the circumstances, you apply those criteria in a very meaningful kind of way. So, whenever I talk about judgment, I dedicate it to the memory of Albie Sachs, okay? We call judgment, but I think it's diagnosis. So, curiosity and context. Yes, cogito ergo sum, I think, therefore I am. Homo sapiens, of course. And I told you that Homo sapiens is an eternally curious animal. Curiosity is the strong desire, it's the passion to know and learn. And to ask why is the most important faculty a professional should develop. I tell this to all my students. Curiosity may have killed a cat, but it never killed a medical student that I know of, okay? Curiosity used in the right context is eminently rewarding. Of course, if you're going to dig in to find out, as I told you, who's going out with whom, you may end up in a mess, okay? And I believe that medicine without context is akin to quackery. Life, indeed, if it is lived without a context, is worth very little. You just have to ask an amnesiac, somebody who's lost his memory. Because if you have lost your memory, you have no context at all. And then life becomes completely meaningless. All right? Now this is, this is a cushion cover that has been done. It has been embroidered by one of my students called Pooja. And you see what she has written over there? Wiseness Days. Because every Wednesday, I used to have a meeting with my students, and it ended up for me asking why. Why? You see, you're calling it this? Tell me why. So when she left, she was very good at embroidery, very good at baking, very good at cooking. All right, she was also a very good pathologist, okay? So she's a very good everything. And she gave me this little thing which I treasure. I still have it with me. It's there on my easy chair. And it's an owl. Now, an owl can mean two things, okay? The owl is a wise bird in some parts, but it's also an ullu, okay? So what I'm saying is, please, please, please ask why. Thank you very much indeed. I really hope that this did tribute to the memory of the soul that we are actually remembering today, Dr. Ramdev. Thank you. Sorry? Thank you very much, Asitovo. That was the purpose of my talk.
And one thing I add is that why you told low power of microscope to be used. That was told Professor B.N. Datta in PGI. Use low power of the microscope with highest power of brain.
Yes, that's right. Excellent. Yes.
Thank you, ma'am. When I first talked to Dr. Anita Borges about the topic she is going to take at this oration level, she said, I'm not going to talk anything about salivary gland tumors or lymph nodes or nothing. I'll talk something general. Now, this general talk you have given today is more teaching, more knowledgeable to us. Even at this age, I'm still, I was learning, but I was not, I'm still learning. And till now, I was just going by what has been taught to me. Today, I know what learning is really today.
You know what learning is and you have been learning. I've just put it into words. That's all.
Ma'am, actually today is a great day for me also, because Ramdev ji was my guide, and in a real sense, as you said, there should be education rather than learning. So he, in real sense, he educates us. And secondly, madam, it is my, I'm quite fortunate that today I am sharing dais with such a dignity, madam. Your topic, when I read about this topic, I thought that madam have a lot of to explain. You have, your treasure is such a big, and you have chosen this topic. But today we knew that why you are unique, ma'am. And Dr.RCPurohit sir, to share my chair with Dr.RCPurohit sir is again, I can't say that today is a good day, or I'm quite fortunate and thankful to organizing committee. So to be with you, ma'am.
Thank you very much, ma'am. Now I would invite our chairpersons to please hand over the mementos to ma'am. I would now like to invite Dr. Yogiraj sir to please hand over the mementos. Yes, ma'am. To our chairperson. Thank you very much, ma'am. Thank you very much, sir. Our next lecture be from Dr. Sumit Gujral, sir. Well, sir also doesn't need any introduction. Sir, currently, sir is Professor, Department of Pathology, Tata Memorial Center, Mumbai. And field of interest sir is having is in oncopathology, hematopathology, lymph nodes, marrow, bone marrow, and flow cytometry. To chair the session, I would like to invite Dr. Ranjana Solanki, ma'am. Dr. Ranjana Solanki, ma'am, and Dr. Paras Nuwal, ma'am. Ma'am is from JLN Medical College, Ajmer.
Good morning. Okay. I wish to thank the organizers, Dr. Purohit, and the RAJPATHCON to have us here in Jodhpur. It's sooner for me. I was here a few months back. Thank you very much for having me again. My talk today is on high-grade lymphomas, aggressive B-cell lymphomas. So talking about high-grade or aggressive B-cell lymphomas for 1 hour, what I've done is I give you a brief introduction about lymphomas. Then I will talk about what is new in WHO 2023, and then I have some cases of high-grade B-cell lymphomas. Broadly, lymphomas, we know that are Hodgkin's and non-Hodgkin's. Hodgkin's are more than non-Hodgkin's are more than Hodgkin's. And pointer is there? And do you have pointer? Mouse here. Okay, cursor. So non-Hodgkin's lymphoma could be B-cell or T-cell types, and rarely the other subtypes. Hodgkin's is almost always a B-cell phenotype. And then the lymphomas could be low grade, means they could be very low grade, indolent. They could be low grade, and they could be very high grade. So the indolent are those lymphomas which are like you can leave them alone. You don't have to do anything. Like MGUS or monoclonal gammopathy of undetermined significance, or monoclonal B-cell lymphocytosis, or CHIP, clonal hematopoiesis. So these are like normal, some mutations or some M-band we have. Maybe few of us in this room will also have M-band, and we don't need to treat them. So those are very indolent lymphoid proliferations. Then we have low-grade lymphomas like CLL, SLL, margin zone lymphomas, follicular lymphomas, low-grade. Then we have aggressive lymphomas. So today I will be more talking about aggressive, and those are the B ones, not the T ones. Most of the T lymphomas are aggressive, most. So T-cell lymphomas you will hardly diagnose low-grade, very, very few. So most T lymphomas are aggressive, and B-cell lymphomas can be low-grade, indolent, and aggressive. Now this is the new WHO book coming up in a month or two, which divides all leukemias, lymphomas into 6 chapters. And I'm going to talk about the part of third chapter, which is B-cell lymphoid proliferations. This chapter is further subdivided into 5 chapters, and I will be talking onto the B subchapter and the C subchapter. Precursor, both those are high grade, and mature B-cell lymphomas. Now if you look at the precursor, which are blastic, they're all high grades. So almost 24, 25 types of blastic lymphomas we have in the new WHO. And then we have mature B-cell lymphomas. And now these mature B-cell lymphomas are maybe around 12 types. The top 6 are the low grades, and the lower 6 are generally the high grade aggressive B-cell lymphomas. So B-cell lymphomas mature are 12 types. The top 6 are the low grade ones. The below 6 ones are the high grade ones. And most of my talk today would be focused on large B-cell lymphomas, which are 18 types. The large B-cell lymphoma itself is 18 types. So you see that lymphomas are so many types. Lymphomas, leukemias now defined based on history, clinical, which site they come from, their ontogeny, mature, blastic, and molecular. There's so many lymphomas defined on molecular. So we have almost 200 or more than 200 types of lymphomas, leukemias now. Now if you look at the large B-cell lymphomas, there are 18 types. There's so many types. And in my practice, there are few lymphomas I have never diagnosed. I have never diagnosed, like I can tell you these two entities. Like I've never seen a breast implant lymphoma. Anita has seen maybe one or two, few. I have not diagnosed myself. My colleague has one actually. So we don't see, and fibrin I have never diagnosed. So the rest are mostly we have seen. Now the question is, what is a large cell lymphoma? I'll just give you an example. There's a young male has a cervical lymph node 4 months, and biopsy was done. And generally our practice, when we see a tumor, this noise is coming from here. I was wondering it's coming from there or here. It's okay. I should not move much. So this is a malignant tumor. We know that looks tumor. This is mitotically active. So what do you do next? So we are taught, postgraduates are taught that any tumor, though in my practice I would think of lymphoma because I do lymphomas. But if you are not a lymphoma specialist, you think of a carcinoma or a melanoma or lymphoma. So you do some stains, maybe cytokeratin, LCA and S100. So we did cytokeratin and LCA. LCA is positive, so it becomes a hematolymphoid. And they are large cells. They are very large, mitotically active, large cells. So it's a high grade, it's a large cell lymphoma. So now is a T lymphoma or a B lymphoma or a NK lymphoma or a plasma cell lymphoma. For that we need more stains. So you do CD20 for a B cell lymphoma. And 20 was positive. So it becomes a large B cell lymphoma. So this is my diagnosis now. So if I give this diagnosis, my clinicians can treat. I don't have to do other 100 markers, which WHO says. If I have, I should do it. But if I don't have it, I can give this much diagnosis and my clinicians can treat. Mostly they give 4 drugs, CHOP with rituximab, RCHOP we call it. 6 cycles of that, 4 to 6 cycles. But the large cell lymphomas, as I mentioned, they can be of different lineages. They won't be only B. Look at the first top, it's a Hodgkin's. That histiocytic sarcoma is also large cells. This is a plasmablastic lymphomas which are associated with HIV. Anaplastic large cell, which is a T cell. So many large cell lymphomas, not all of them are B cell. So we need to do 20, we need to do 3, we need to do CD138, MUM1, other markers also, ALK, 30. So large cell lymphomas can be of different lineages, but commonly they are B cell types, and most of the large B cell lymphomas are CD20 positive. But there are large B cell lymphomas which can be CD20 negative. Now if you look at on the left side, Hodgkin's is a B cell lymphomas, it is 20 negative. Similarly, plasmablastic lymphoma is a B cell lymphoma, it is CD20 negative. Similarly, there are small cells, small B cell lymphomas, small size, like lymphoblastic lymphomas. B lymphoblastic lymphomas are also CD20 negative. Even CLL or SLL can be CD20 negative. So 20 is not the best marker for B cells, as we discussed day before yesterday in the college. 19 is a better marker, CD19 or PAX5 for B cells. 20 is not the best marker. 20 is used for the rituximab targeted therapy. Now, in our practice, I said, if this is a large cell lymphoma, I will do 3 stains, CD3, CD20 and MIB1. So these 3 stains gives me a diagnosis, and MIB1 is a proliferation marker. It gives you more confidence. Yes, it's a high, it's more than 30-40%. If it is a 10% or 20%, you doubt, It may be a low grade or marginal zone. Sometimes it can have more cytoplasm, can look like DLBL. So MIB1 is a good marker. So these three markers we generally recommend that you do for all large cell lymphomas, if you cannot do more. So at least these three markers do for large cell lymphomas. But if you have a facility, you end up doing 7, 8, 10 or sometimes 12, 14, 15 markers. Because large B-cell lymphoma could be EBV positive, could be CD30 positive, could be CD5 positive. These all have diagnostic as well as prognostic significance. So more the merrier. But you have three markers which I told you in the beginning, they are the most important markers. As I mentioned, the WHO says large B-cell lymphomas are 18 types. 18. Now, what are the aggressive lymphomas? Most of the large cell lymphomas are aggressive, as I said, most large cells. And few small cells also are aggressive, like lymphoblastic lymphomas are small, but they're aggressive. Mantle cell lymphomas are small, but they are aggressive. So mantle cell, lymphoblastic are also very aggressive, like other large B-cell lymphomas. And T-cell lymphomas, mostly they are aggressive. Now, if you have to define large B-cell lymphomas or aggressive B-cell lymphomas, there are three types. One are the de novo, which they start with high-grade lymphomas. Large cell lymphomas are aggressive B-cell lymphomas. They don't have any history of immune deficiencies. Second ones could be the rare ones, which are they were low grade once upon a time, and they transform to high grade. And third ones are further uncommon ones, high grade lymphomas associated with immune deficiencies, like HIV or some drugs related, or transplant, post-transplant. These are uncommon lymphomas, but the commonest one is the first one. Now, if you ask me the four commonest types of aggressive, now I'm not talking about large, I'm talking about aggressive. These two terms can be used interchange, but it is not true, because aggressive could be small cell lymphomas also. So I'll be focusing more on the word aggressive, which will take care of all large cells and 2-3 more types, mainly mantle cell, lymphoblastic and Burkitt's. So 3 more types come into the large aggressive B-cell lymphomas. Which are the aggressive B-cell lymphomas? One is the large B cells, which has almost 17, 18 types. Almost all of them are aggressive, almost. Mantle cell lymphoma, B lymphoblastic lymphoma, Burkitt's. These are small to intermediate size. These are not the large size, but they are all aggressive. Now, in our practice, when we do practice, we have a problem between two entities in aggressive B-cell lymphomas. We know tumor cells are intermediate to large, and they are 20 positive. But we have a problem in these two entities. One is large B cell, second is high grade B cell. So there are two different entities mentioned in the WHO now. So we have to be aware of this. And third entity would be Burkitt's. They have overlapping features, like large B cell, high grade B cell, then Burkitt's. So this is something like Burkitt-like. In the older books, times we used to call it Burkitt-like. Now we don't use the word Burkitt-like. So there are proper definitions in the WHO now. The large B-cell lymphomas are generally large size cells. They have 1 to 2 to 3 nuclei, round to ovoid nucleus. And the high-grade B-cell lymphomas are they're intermediate size. They're not large size. They're less pleomorphism. And their nuclear chromatin is more blastoid. So high-grade B-cell lymphomas look more like blastic or look more like Burkitt's, but they fall short of Burkitt's and blastic in their when you do a workup. They don't look like DLBCL. So it's a basically very morphological diagnosis. IHCs will not help you differentiate these two. It's a morphology. IHC will help you differentiate high-grade B-cell lymphoma from blastic and Burkitt's. Maybe. But these two we differentiated based on morphology, because both are CD20 positive. Both are MIB1 80%. So these are the two entities in our practice we use now regularly, and they have some overlapping features. Like this DLBCL and high-grade B-cell lymphoma. Now Burkitt is more classical, round, monomorphic tumor cells full of apoptosis and necrostem mitosis. These all are aggressive B-cell lymphomas. Now the WHO says that we used to define DLBCL into 2 types, cell of origin, ABC, GCB types. We still continue to do that, but WHO says it's not mandatory to do that. For that we need additional IHCs, CD10, BCL6 and MUM1. But it has to be done by genomics method, because it's not the best way to do. Surrogate markers are IHCs, but it has been seen that it is not the foolproof method of differentiating good from the bad ones. Because we know that DLBCLs, diffuse large B-cell lymphomas, or the large B-cell lymphomas are the commonest lymphomas we see in our practice, followed by Hodgkin's. Now, large B-cell lymphomas, when you give chemotherapy, which I said most common is R-CHOP, is 4 to 6 cycles. 50% patients, they die within 2 to 3 years. 50% patients survive. They live long. So how to differentiate the good from the bad one? For that, genomic studies were done on thousands of cases of lymphomas, and 2 categories were formed way back, 20 years back, by Alizadeh and the 2 papers, Rosenwald as Alizadeh groups, onto ABC and GCB types. So ABC was more aggressive and GCB was good one, germinal center B type, activated B type. But it has been seen that IHC is not mandatory to do. But however, WHO says that all cases of DLBCL, you must do FISH, if you can do. Yeah, again, doesn't say mandatory, but prefer to do FISH and do at least MYC by FISH, 1 marker, all cases of DLBCL. At least the GCB type. We'll talk about that. I think this is the pictures I've taken from my friends, Mayur and my colleague Dr. Dhanlakshmi from Tata Hospital, the Burkitt's lymphoma. This is from Sridhar. Now this is a case of Burkitt-like 11q. This is a new entity, high-grade B-cell lymphoma with deletions of 11q. Now, as I mentioned, there are 2 types of lymphomas, mainly large B-cell and high-grade B-cell. If these lymphomas have MYC and BCL2 translocation, we give it name as DLBCL with MYC and BCL2. And if they don't have, we call it DLBCL NOS. So NOS is used only once you have done more FISH studies. You can't use the word NOS otherwise. So DLBCL NOS can be used only in the premier institutes which doing all the tests and all the clinical findings, all properly investigating. Now if you look at this slide, it shows you the various types. I told you all these are types of DLBCL, and these are the other small to intermediate size high-grade lymphomas. There's so many types of aggressive lymphomas we have. Why do you want to subtype them? Because the treatment is now different. Initially we thought there's only one ABVD for Hodgkin's and R-CHOP for B-cell lymphomas. No, but there are many new protocols now. For blastic it's different, for Burkitt it is different, for mantle cell it is different, and these are the very aggressive. These are the very bad high-grade lymphomas. They are given a regimen called as dose-adjusted or EPOC. So these are like mediastinal lymphomas, gray zone lymphomas, DLBCL with MYC and BCL2. Those are aggressive tumors, the most aggressive. Now how do you approach? Just briefly, I'll show an algorithm. As I said, the most important is morphology, HND slide, where you define whether this is a large cell or a blastoid intermediate cell. We do 3 stains, 320 and MIB1, and based on that we call it DLBCL or high-grade B-cell lymphoma. So this diagnosis we base it on morphology and CD20. Only these 2, morphology and CD20, we call it either DLBCL or high-grade B-cell lymphoma, based on morphology, whether they're intermediate blastoid or they're large cells. Then we do additional markers like CD10, BCL6 and MUM1 to call it, is it GCB type or ABC type. Once it is a GCB type, the recommendations are we must do FISH in all cases of GCB types. If it is not GCB, you might not do MYC studies. So we do MYC break apart FISH in all cases of GCB. If MYC is positive, then we need to go for BCL2. If MYC is negative, no need to go to BCL2. So these are the algorithms to save money also, and this is the way you can do not FISH in all cases. And markers, as I told you, and these are on the left side are the other lymphomas you have to keep in mind. Now, it's interesting to see that we are doing more big apart MYC in GCB type, and we said GCB is a good one. I mentioned that German center is for G is for good. It is good one. ABC is a bad one. But we have seen that the worst lymphomas, the worst ones are these ones. The low order DLBCL with MYC and BCL2 and high-grade B-cell lymphoma. Those are the worst lymphomas. They come from the GCB category. So the worst lymphomas come from the good category, which are 2 to 8%. So we have to pick up those 2 to 8% which are really very bad. So I don't think all 50% patients die. Then I said maybe 60% patients live well, around 30 to 40% patients die. And those 30 to 40% patients die, most of them are from that category. Most of them. So we have to pick up those ones. For that, there is an algorithm which I just shared with you. Yeah, Miss. Yeah. So briefly, these are the mandatory stains. A good morphology, 3 and 20 and MIB1 to do aggressive B-cell lymphomas. At least start with these, and then preferable is many markers, and also to do a FISH analysis. That's a preferable. Now, aggressive B-cell lymphomas, I'm just revising it, the WHO to you to make it a little simplify. I've taken help from Naresh here to a few slides. Next 1 or 2 slides are from him, actually part of them. Now, aggressive B-cell lymphomas can be classified based on many things. Let's say it can be classified based on the site. There could be immune privileged sites. Now, which are the immune privileged sites? Brain, vitreoretinal, and the testes, where there are barriers. They are the centuries. So they are called immune privileged sites. And they are all ABC type. Skin, cutaneous lymphomas are different. Mediastinal lymphomas are also different. Then you have, based on morphology, we discussed that. Then we have context. They could be long-standing with fibrin, they have fluid overload, and effusion-related. Now, effusion-related could be HIV or HHV8. Then you have lymphomas associated with viruses, like EBV or Kaposi sarcoma virus. Then we have tumor microenvironment. There could be lymphomas which are rich in T cells and histocyte rich, like T cell, histocyte rich, B cell lymphomas. There are lymphomas which are lymphomatoid granulomatosis, which occur in lungs primarily. They have angiocentricity, angioinvasion. In the lungs, they have multiple nodules. They look like infection sometimes. You can miss them, these lymphomas. EBV associated, these are. Then we have chronic inflammation associated lymphomas. Then based on the size, the large size, there are different types of centroblastic, immunoblastic, plasmablastic. We have been classifying using this for many, many years now. Then we have medium size, as I already mentioned, blastic, Burkitt's, blastoid. Then there are aggressive B-cell lymphomas driven by EBV and other clinical and morphological features, like, as I mentioned, lymphomatoid granulomatosis occurs in lungs. EBV positive DLBCL used to be called it elderly, but it can be seen in youngs. Now DLBCL with chronic inflammation and fibrin associated. So these are the different pictures you get. I just taken some pictures of small cells, aggressive lymphomas, intermediate size, and large size lymphomas. Now you can divide high grade these aggressive lymphomas based on genomic studies now. Now genomic studies I mentioned, these are the 4 or 5 common markers: BCL2, MYC, 11q, ALK, and IRF4. These are very important markers now, because I'll show you an example if we have time. That IRF4 lymphomas, which generally occurs in tonsils, they look like large B cell or could look like follicular. They are strong MUM1 positive. So any follicular lymphoma in tonsils area, don't call it follicular, do MUM1 at least. If MUM1 is strongly positive, most likely you are dealing with a lymphoma called as large cell lymphoma with IRF4. They are low grade. They are not high grade lymphomas. So there even the chemotherapy is of less intensity. Now genomic groups are 2 types, GCB versus ABC, which is an old one, now 20 years old, and now we have the newer classifications. Now I'll share with you, this is the old one now, almost 2000 Alizadeh. Now the new genomic classification is 7 subtypes. It is Wright et al. Paper came in 2020. Now it's based again on gene expressions, mutations, and translocations, and copy number alterations. If you see this, there are 7 subtypes the group has defined. MCD. MCD is MYD88 with CD79B. BN2 is BCL6 translocation with notch mutation, notch 2 mutations. N1, notch 1. So here if you look at the yellow color is MCD and N1. They are genomic types, but they are associated with ABC. ABC means they are 10 negative, BCL6 and MUM1 positive on IHC. these are the two subtypes, MCD and N1. These are associated with, they are mostly with ABC subtype, and it has been seen that these aggressive lymphomas, if you add ibrutinib, there's another drug, ibrutinib, these patients have 100% survival. 100% survival. So these are new studies, preliminary studies. So we are learning. So it hasn't come part of WHO right now. But it's important to know what is the importance of this genomic classification. So these are the worst lymphomas which come from ABC category, but they have 100% cure. If we add one more drug, ibrutinib, in our chop. My colleague Gaurav has made a panel in our lab for lymphomas. It's almost 205 genes and supplementary 55 gene are in a panel based on all this. What was the criteria? How did he approach? Just quickly I'll share with you. How do you make a panel? How did he devise a panel? So he thought of 2-3 things. First, he thought which are the diagnostic markers, then which are the most common frequent mutations, and which are the defining mutations like MYD88 for Waldenstrom's, BRAF for hairy cell leukemia. So based on the common mutations, frequent mutations, and also therapeutically important mutations, we have made a panel of 205 DNA and 55 RNA genes. I think I'll skip this. Now I have cases. I think I will take 15 minutes. I have 10 cases, but I'll take 1 minute case. But you should see this, pathologists. A young boy has abdominal mass. So young boy has an abdominal mass. If it is lymphoma, it has to be Burkitt's. If it's a young boy has an abdominal mass, you think of Burkitt's. And Burkitt's is a lymphoma which mostly occurs in extranodal sites, breast. If you have a lymphoma in breast, ovaries, think of Burkitt's other than DLBCL. If it's CD20 positive, and then obviously look at the morphology and other markers. So this is going into the, you can see the part of GI, and it's monomorphic high-grade tumor cells. You do these markers. CD20 is strongly positive. TDT is negative, it is a blasting marker. Then you do 10 is positive, MIB1 is 100%, and BCL2 is negative. So this is very classical morphology, site, history, and IHC profile of Burkitt's lymphoma. So in the context, it is Burkitt's lymphoma. You need to do these two things in all Burkitt's. We do not do in our hospital. You need to do CMYC in all Burkitt's to make it sure it's a Burkitt's. You have to have CMYC. If CMYC translocation was negative in this case, then you have to think of 11q aberrations or something else. So, but we don't do. And Eberish, the WHO recommends you must do in all Burkitt's. Though there's no significance of Eberish, but molecularly Burkitt is of two types, Eberish positive and Eberish negative. Old times, Burkitt was the sporadic, African type, endemic types. Now it is no more considered those types. Now Burkitt is two types, Eber positive and EBV negative. Yeah. 52-year-old male, upper alveolar mass. Now 52 male, upper alveolar mass and seropositive. So only one diagnosis you have. If it is not a carcinoma, if it's not a poorly differentiated squamous carcinoma, it will be plasmablastic lymphoma, because it occurs in HIV patients, homosexuals, and mostly occur in the buccal mucosa and the anal canal. So morphology, you see the mucosa, and there is a busy submucosa which shows these large sized tumor cells, brisk apoptosis and mitosis both. And you can see the plasmacytoid cells. They look like immunoblast or plasmablast. So what do I do now? I do two stains, CD3 and 20. 3 will be negative most likely. 20, if 20 comes positive, then it's a DLBCL. If 20 comes negative, then I need to do, maybe LCA I do, because I think it could be carcinoma. So I do cytokeratin negative. LCA is also negative. So LCA negative, 3 negative, 20 negative. We need to do markers for plasma cells, which are CD138, CD38, MUM1. So it was positive for, you see cytokeratin is negative, AE1A3 is cytokeratin, 20 negative, PAX5 negative, 138 and MUM1 both are positive. So this is plasmablastic lymphoma. You could do Eber-ish in this, and this was positive. So this is a lymphoblastic, this is a plasmablastic lymphoma, which, as I said, it occurs commonly in the extranodal sites, only the buccal mucosa and the anal mucosa. Case 3 is a 37 male lymph node biopsy. He is fit, otherwise viral markers, nothing, but he has nodes supradiaphragmatic and infradiaphragmatic. So lymph node has come to us. This is a cervical lymph node. They're fragments. And you can see there's some hemorrhage there, and there's a tumor which looks like small to intermediate size with some capillaries, blood vessels, hyalinized capillaries, and monomorphic small to intermediate size cleaved lymphoid cells. So when you see this kind of picture, this is not very beautiful picture on the hair, but you start thinking of blastic lymphoma or mental blastic. If it's a child, you think of a lymphoblastic. If it's an adult, you think of mental blastic or mental lymphoma. So you do 3 is negative, 20 is positive. PAX5 is another B cell marker, positive. So it's a B cell lymphoma. So rarely follicular lymphoma can also look like this. Sometimes it can have a diffuse pattern, but it looked more mantle. So we did 5. 5 is positive. You see the 5 is a T cell marker, and 3 is negative. So 3 is a T cell marker, 5 is also a T cell marker. Now 5 comes positive in CLL and mantle cell lymphoma. 5 is a T cell marker, but comes positive in 2 B cell lymphomas, CLL, mantle, and rarely in DLBCL. Then we call it CD5 positive DLBCL. It's a rare entity. But then we have to do SOX11 and cyclin D1 in those cases to rule out pleomorphic mantle, which is again very rare. So cyclin D1 is positive. 43 is another good marker. MIB1 was very high. So based on morphology and high MIB1, it was called as blastoid variant of mantle cell lymphoma. Next case, 57 male lymph node biopsy. Otherwise, low grade fever, viral markers negative. Adult, cervical lymph node. So this is again a diffuse pattern. Looks like small blue cell, looks very blue and small cells morphology. Mitotically very active. You can see so much mitosis here. But monomorphic cells, again looks like either mental or lymphoblastic. If it's an adult, I'll think of a mantle blastic. If it's a child, I'll think of a lymphoblastic, T lymphoblastic. Because B lymphoblastic is rare. So let's see 3 and 20. Look at these cells. They look very fine chromatin. You see the chromatin. You can look at mitosis. Monomorphic cells. They don't have a nucleoli. Diffuse pattern. 20 is positive, so it can't be T lymphoblastic. And B lymphoblastic, which is very rare, it is also negative for 20. So it can't be B blastic. It can't be lymphoblastic because 20 is strong. So it has to be mantle. This morphology and this strong 20 has to be mantle. You could do other stains. 5 is positive. You see that? You compare 5 from 3. The 3 is some cells are strong. These are the normal T cells. These are the normal T cells. The tumor cells are negative. Here also you have some strong. These are the normal T cells. The tumor cells are weak. So 5 and 3 both are T cell markers. And we can, take help. And tumor cells express 5 and 20. So it's either CLL or mantle, but it didn't look like CLL morphology. So possibly mantle. So we did cyclin D1, it was negative. We did BCL6, it was negative. 10 was negative. So is it a CD positive DLBCL? It didn't look like large cell. It looked like intermediate size blastoid chromatin. So we did SOX11, it was positive. So there's a few more markers you need to do. You can't stop at, as I told you in the beginning, 3 and 20 is enough. But if you do more lymphomas, then you realize, markers keep on adding to your kitty. So this is again a blastoid variant of mantle cell lymphoma, but it was cyclin D1 negative. We need to do another marker, SOX11. Yeah. Next case, young boy orchidectomy. Now, young boy orchidectomy, it has to be lymphoblastic lymphoma in a case of ALL. So, morphology, you have some seminiferous tubules, remnant, and the tumor is kind of infiltrating. And again, small, very blue looking, small monomorphic cells, blastoid chromatin. There are some remnant, there are small seminiferous tubules. This is a young kid, this is a 5-year-old boy. 20 is negative, 3 is negative. So what do you do next? I told you the commonest is B cell ALL. So what do I do? CD19 I'll do, PAX5 I'll do, or 19 I will do. So I don't have 19, so I did PAX5, it was positive. CD10 strongly positive. It has to be B lymphoblastic lymphoma. I'll do TDT, and 34 is positive. TDT I do not know if I've not shown. I thought TDT was positive, but anyway, I don't have TDT here. So 34 is positive. So it's a B lymphoblastic lymphoma in testes. So many B cell lymphomas can be 20 negative. Many B cell lymphomas can also be LCA negative, like Hodgkin's, plasmablastic lymphoma. ALCL is T cell lymphoma, can be LCA negative. So doing only 1 or 2 stains, you might be missing lymphomas. In next case, young male, female, anterior mediastinal mass. Now, anterior mediastinal or supraclavicular node, young female, you think of, I'm ruling out germ cell, I'm doing only lymphomas. Which are the common lymphomas? I'm not talking about thymomas now. Lymphomas in Hodgkin's, gray zone lymphomas, PMBCL. These are the common lymphomas there. So these interior mediastinal biopsy, you can see sclerosed fibrotic. 2 cores are very fibrotic. There are 1 or 2 cores, there are areas which are cellular. You can see some areas are cellular, some are fibrotic. So this is a classical picture of primary mediastinal large B-cell lymphoma, PMBCL. It can look like Hodgkin's, because Hodgkin's disease nodular sclerosis will also show you fibrosis. So there is an overlap between these entities, Hodgkin's, PMBCL, gray zone lymphomas. There can be problem in diagnosing on needle core biopsies. But then we take help of morphology and we do some stains. These are the sheets of large cells, they're large tumor cells. Hodgkin's will not be like this, these kind of large cells. So you do cytokeratin, you can see some thymic tissue, and you do 20 is positive. Then if you have 23 and 30, you can also come positive. So these primary mediastinal large B-cell lymphoma, they express CD30. So CD30 is not a marker for Hodgkin's and ALCL. 30 is just an activation marker, can come in germ cell tumors, can come in DLBCLs, can come in PMBCLs. So CD30 alone can be positive in normal immunoblasts. So as Anita showed you a case, it was benign doctor's son who had EBV 30 positive cells. It was not Hodgkin's. It was EBV related proliferations, infectious mononucleosis. So 30 is one marker which will take you to the court maximum times in your lifetime. So you have to be careful of CD30 positivity. If you have CD200, these tumor cells express CD200. So it was primary mediastinal large B-cell lymphomas. These are all high-grade aggressive B-cell lymphomas. These are the, which is the highest mountain in India, mountainous peak? Anyone? Huh? Sorry? K2? ये तो कोई बहुत ही देशभक्त है. Who wants to capture Pakistan? K2 is Pakistan. Kanchenjunga is in India? Sure? The peak is in Nepal. The Kanchenjunga has a range. The main peak is in Nepal, the highest peak. The lower areas are in India. Huh? K2 is in Pakistan. Nanda Parvat is also not in India. Nepal. The top 8 peaks are in Nepal, in Pakistan. India has actually not many peaks. So these are the Nunkun peaks which are in Ladakh. These are Nunkun, they're 24,000. They are, I think, in the top 10. So I think these are amongst the top peaks in India. So Mount Everest is 28,800 something feet. This is 24,000 or 23,000. So the top 10 peaks are not in India. We proudly say that we have Mount Everest, Himalayas with us, but the peaks are in Nepal. Next case, 35 male, generalized nodes, and this supraclavicular node. There's quite a few, many things I've learned from Anita. This is again one more thing. Supraclavicular is part of mediastinum. So if you have a node in supraclavicular, think of Hodgkin's. So you can look at the cores. There's a fibrosis, there is necrosis, there are nodules. So you can see some necrotic areas, fibrotic areas, sheets of tumor cells. So you think of Hodgkin's lymphoma, it doesn't look like classical RS cells, but there are RS-like cells. But then there are sheets of large cells. You see the sheets of large cells abnormal. So differentials were these. We did some IHCs. And you look at 20 was positive strongly. Now 20 strongly positive takes you away from Hodgkin's. Hodgkin's lymphoma is CD20 negative or weakly positive. So if 20 is strongly positive in mediastinum and rest of the markers 15, 30 they come positive, you are basically thinking of a gray zone lymphoma. So based on morphology and strong 20 positivity and other markers, it was called as gray zone lymphoma. This is a high grade lymphoma, very high grade lymphoma. This again doesn't need ABVD, you need special chemotherapy. As I said, dose adjusted R-epoch. R is rituximab and epoch are 5 drugs. Again, it has been defined into two types, Hodgkin's-like or PMBCL-like, because it can have features. As I said, these are the three entities, Hodgkin's, PMBCL and gray zone lymphomas in mediastinum. They have overlapping features. Now, what is this thing, anyone? In the center? It's a glacier. This is the way the glacier looks like. Not somebody will take you to Sonamarg and show you a small white snow on the top of a mountain. Is a glacier. That's just a snow collection there. It may be glacier behind. So glacier has to be like a river, frozen river. So this is a nice frozen river. Frozen river, this is a glacier. So can anybody tell me this is India? Which glacier is this? Huh? Anyone? Sir? It is in Ladakh. It's the most beautiful glacier in India. Many of you must have gone to Switzerland, but nobody has gone to Ladakh here to see this. Huh? You been? So tell me which glacier. You've been to only Leh, you touch the Patel points. They call it, sorry to say that, they call it Patel points. You know, you go to 5 points, you know, you go to the lake, the museum, and come back to India, come back to Bombay. So this is not in the routine area, this is in the Jhanskar Valley, near the Jhanskar. This is Drang Drung Glacier. Drang Drung, most beautiful glacier you see. You go to this New Zealand, other countries, they'll charge you $10 to show you glacier. The entry to glacier, they charge you $10 and you see a small piece of ice there. You go here, it's free. I'll take 5 minutes. 21 male, young boy, colonic mass. So, now what do you think? Young male colonic Burkitt's most likely, if it's a lymphoma, or DLBL, rarely T cells you get, you know, EATL, entropy, we rarely get with the celiac diseases. They are in the small intestine though. This is colonic. So you have fragments of colon and some mucosa has some lesion, and you see this very active tumor, busy, large size, nucleolated. These are having nucleoli, I can see that, nucleoli, prominent nucleoli. Large cell lymphoma. So I'll show you more pictures. Yeah, this is some pattern also. It looks like a sinusoidal pattern or nesting pattern, whatever. So you start thinking of ALCL. So either DLBCL or ALCL. Mitotically active. Plasmablastic morphology. So differences were same. DLBL, ALCL, plasmablastic. We did LCA and 3 and 20 both are negative. 138 is positive, which is a plasma cell marker. And 138 also comes positive in carcinomas. One has to be careful. So alone 138 is not helpful. So MUM1 can also come positive in many ALCL. Even solid tumors, melanomas can show you. So you have to be careful. So MUM1 is negative, so I'm not going to call it plasmablastic now. Only one plasma cell marker, I have to be careful. So here I do an additional stain called, which is ALK1. So this is a case called as ALK positive, large B cell lymphomas. ALK was positive, you see the granular cytoplasmic positivity. So ALK positive, MUM1 negative. So ALK can be positive in ALCL, can also be positive in B cell lymphomas. ALK positive, large B cell lymphomas. You do ALK in the lung tumors also. So you don't think that ALK is only marker for ALCL. 9th case, ileal mass, 32 female, classical Burkitt's. Ileal, I said ileal is a common site. They come with intussusception. The kids come with obstruction, a distension abdomen. This is the classical morphology. It's round cells, monomorphic with apoptosis. And you do these 3-4 stains, 20, 10, BCL2 and MIP1. BCL2 is negative in only one lymphoma, Burkitt's. Rest, all lymphomas are BCL2 positive. Normal lymphocytes are also BCL2 positive. So BCL2 only helps you in Burkitt's. Mostly it's useful here. Now this is a main river in Ladakh. Can anybody tell me which is the main river in Ladakh? Oh, sorry. You have to tell me. Now this, if you don't tell me, then there's no point discussing large cell lymphomas. This is a main river. Our country is named after this river. Indus. This is Indus River. You were telling, madam? Yes, thank you. At least chairperson knows. See, nobody knows. This is a mighty Indus. This gets 15 big rivers, bigger rivers than this. And then it enters Pakistan. It's almost entering Pakistan. This is Batalik, Darchik area. Another case, young boy, I mean, this is a flow. I will not show you flow. This is a case of Burkitt's. You can diagnose Burkitt's on flow also. We have markers, like newer markers, like CD81 is positive strongly in Burkitt's. 44 is negative. Classically, 44 comes positive in diffuse large B cell lymphomas. Yes. These are the ladies who came with us. The men thought, let's leave them and as a pose and we should take our cars away. The posing for the picture. Next case, another interesting case, quickly I'll go through. Breast lump, 33 female. Now, breast lump, 33 female lymphoma has to be Burkitt's. And if you look at the morphology, monomorphic round blastic cells or they don't look like Burkitt's. Fine chromatin, mitotically very active. Maybe Burkitt's, but maybe blastic. High grade. This is the morphology. They're all 20 positive. There's some pleomorphism here, mild maybe. So we did stain 20 positive. MIB1 is 95%. BCL2 was positive, almost 100%. So here MIB1 and BCL2 both are positive, which is unusual because they're like BCL2 is anti-apoptotic and MIB1 is proliferating. But they are both positive, so we couldn't call it Burkitt. 10 was positive. MUM1 BCL6 positive. MIC was very high, 60-70%. We had to call it high-grade B-cell lymphoma. We couldn't call it Burkitt's. And we couldn't do, this old case, we couldn't do 11q aberration studies and CMIC here. We should have done that. This could have been a case of high-grade B-cell lymphoma or Burkitt-like lymphoma with 11q aberrations. A young boy, left inguinal region swelling. Now this is Sridhar gave me this case. I have a case with me last week. I couldn't bring it. This is an inguinal node, has got a nodular pattern, small intermediate size blastoid cells, mitotically active, intermediate to large size cells. Intermediate to large size blastoid cells, inguinal node. We did markers, 20 positive, 10 positive, PAX5 positive, and MUM1 was very strong. So a lymphoma which has a nodular pattern and showing you strong MUM1 positivity along with BCL6. You think of IRF4, large B-cell lymphoma with IRF4 gene rearrangements, which generally occurs in tonsils. Now this was inguinal region. It was further, cytogenetics fish was done, and it was proven to be a case of large B-cell lymphoma with IRF4. I have a case recently, I've seen 2 more cases in the tonsils. So this is a low-grade lymphoma, occurs in tonsils, looks like follicular, can have diffuse patterns, generally blastoid morphology, and they are 20 positive, BCL6 positive, and MUM1 is very strong. So if you do MUM1 and MUM1 is very strong in any follicular lymphoma, especially in this Waldier's ring, keep in mind IRF4 lymphomas. These are again the Nunkun peaks. Last case, 57 female, cervical, right cervical lymph node now. Paratracheal lymph node, 55. This is a big node, a lot of hyalinization, and some cellular areas. Hyalinized. They look more spindly, little ovoid. They're showing some patterns, whorls, nesting. So this is a dendritic cell sarcoma actually. You can sometimes get histiocytic sarcomas, which are also high grade. They're not large B-cell lymphoma. I just put this case. And classically you do FDC markers. This came actually 2-3 days back, so I brought it for us. Eberish was positive. So there are 2 entities in WHO, FDC sarcoma and EBV positive inflammatory FDC sarcoma. There are very few differences, but if it is EBV positive, we put it in that category. So to conclude, these are the common types of lymphomas in adults. The aggressive B-cell lymphomas are mostly DLBCL. In children, the aggressive B-cell lymphomas are mostly Burkitt's or they are B-cell ALL. And as I told you, that there are many newer chemotherapy protocols now. So our job as a pathologist has to go beyond 320 and MIB1. We can't stop there because the treatment protocols are different and prognosis is also very different if you treat them aggressively. This I've already told you, mandatory markers and preferable. Preferable is much more. This is preferable when I do in my practice if I get permission to do. These are a group of friends doing lymphomas in Bombay. Thank you.
Thank you very much, sir. I would request Ma'am Ranjana Ma'am and Parul Ma'am to please come and present the moment.
That was really a wonderful presentation, Dr. Sumit, and thank you very much for showing those garden variety of your cases and giving us an insight into the updates. Although by the time we learn the updates, it's time for a new update. So that's what is there in lymphomas, and I think we are carrying some of the queries also, which we will maybe sort out at some other time. Thank you.
Very silly comment. We are all exposed to all types of, the same type of fauna, flora, all types of viruses. I get a high-grade B cell lymphoma. You get a low-grade one. She doesn't get anything. What's the reason? Why? We do the chromosome analysis. एक क्रोमोसोम की टांग टूट के गायब हो गई, एक टांग टूट के उस पर चिपक गई. But what's the reason behind all these things?
I think we should go to Ladakh to find a reason, because I want to be a Lama next life. I'm also trying to find out what's the reason for this. Maybe Anita has context. Anita, you have something to say? I can take my memento and go down. There are difficult questions in this audience.
No, of course that, but I think that this is exactly what I was saying. Curiosity, why?
Why?
And that's the question that Professor Purohit is asking. Right? Why is it that we are all exposed to the same things, and yet now you're asking a question about lymphomas, but I can ask you the same question about a common problem like tuberculosis. Okay, we are all breathing the same air, we are in the same let's say context, environment or whatever, but some people get it and some people don't. Now I think, let me just tell you as far as my own family is concerned, because there's nothing to be ashamed of or in. I have so many people in my family on my father's side and including some of my sisters, who have all suffered from, and my brother as well, from tuberculosis, and they had to be treated for it. My father had a pleurisy, that means which is tuberculosis, when he was in England, and in those days there was nothing, so it was just sanatorium treatment. Okay, my brother has had full-blown tuberculosis and he has had to be treated. My sister has had it. 2 sisters of mine have had it. And you might ask, what is this? So obviously we have some kind of immune response genes, that in our HLA type that are making us susceptible to tuberculosis. You may not have inherited those kind of genes. So I think at the base level is, how do we respond to our environment? And that is really what makes us individuals. Each one of us we may live in the same environment, but I don't have the same genes, just as I don't have the same memories as you have. Okay, so I think that this is where it all, it's not the only thing. There may be lots of other environmental differences, food and other things. But I think basically we are not the same at the genetic level.
To add to that, Anita, same, if 2 of us have tuberculosis, you might respond, I might not respond.
Correct. And it may not be anything to do with the bacillus. It may have something to do with how you mount a response to tuberculosis. Okay, but I wanted to say something, Sumit, about your talk, and particularly the cases that you showed. I think that context was so important in every one of them. All right, you have the age and you have the site, and without these very basic things that are supposed to be in your TRF, that is your test requisition form, I don't think that your histology trumps anything that is seen there. So thank you for bringing out the context. It was very nice following on from whatever I said.
I say that if you have a GI lymphoma in a child, before you go to the slides, IHC and molecular, you know the diagnosis already. You just have to confirm it. Miss, if it's a lymphoma. Thank you.
Thank you so
and
much.
what Sumit said about the supraclavicular lymph node, he said I taught it to him, which is, that is Sumit. But it is true that there is no primary pathology that occurs in a supraclavicular lymph node. Right? It is always reflective of what is in the mediastinum, in the abdomen, or in the So never believe that when somebody says that this is a biopsy of a supraclavicular lymph node, please look elsewhere, whether it is tuberculosis or it is lymphoma. It is always reflective of something that is somewhere else. And it's an important thing to know, so that even when you want to, you've got something that looks like a carcinoma in the supraclavicular lymph node, please look elsewhere, particularly in the mediastinum. You know, you'll find that that's where the clue actually lies. Thanks, Sumit.
Thank you.
Thank you, Dr. Sumit, and especially for such a wonderful talk you have given to us. And I am so thankful to Dr. R.C. Purohit Sahab for inviting and offering this chair for Dr. Sumit Gujral. Thank you so much, Dr. Purohit also.
So, ma'am, please present the memento to sir. I would request Dr. Kishore Khatri sir to please come on the stage to present mementos to our chairpersons. Thank you very much, ma'am. Thank you very much, sir.
I'll just take 1 second. We have a Bombay Lymphoma group. We meet once a month. So we learn together. Nobody is teaching anyone. We're learning together. So it's a good idea to have a group in the city. Once in a month you can. We have senior surgical going for years in Bombay. But Bombay Lymphoma group we formed 10 years back, 15 years back. And it's going very well. So we learn, we bring our difficult cases, sit on a big microscope. We all learn together. So there are many tricky situations where you don't know how to go forward. So you might not have IHCs, but you have history, you have morphology. See? Cat. Curiosity killed the cat.
Crow, I guess. Crow. Now it's a short tea break and then we'll rejoin together. 10 minutes.